we need to take care of ourselves. And people talk a lot about hydrating. And I hadn't seen this before, but you actually have a thermos that monitors exactly how much water you consume.
Yeah, we live in a data world, and why not have one more piece of data? So every time you drink out of it, it records how much you've drank, and it sends an alert to your phone when you haven't had enough to drink.
It'd be interesting when I'm together with my high school buddies, where you've got a trip planned to the Bahamas.
Oh.
I should get those for everybody and have them drink their beer out of those.
You know what? I think you could have a contest. It does record across the board, and not that I would support that.
Hey everyone, Bradley Bostick here, host of Boombastic Health. Really excited about today's topic, which is about the use of subspecialized pathologists in better diagnosing and treating cancer. We've got one of the top leaders of the lab industry here with us in the studio, Steve Serota. Steve, thanks for being here.
I appreciate it.
So Steve is with a few organizations, but I don't know which one to say is his day job, but they're all very related. And it's just super cool to see an innovator like this out there running what is the largest lab in Wisconsin. So as president and COO of Wisconsin Diagnostic Labs and chief lab officer of Freighter ThetaCare Health, and also CEO of more of an early stage business, Adelon, Steve really leverages experience that he's gained from a variety of previous innovators, including Northwestern Medicine and Rush University Medical Center, to kind of bring what I see as the state of the art of laboratory medicine to the benefit of patients.
Yeah, and that's been really the focus from the beginning, right? If we can bring the best and the brightest and the most cutting edge innovation right to the patient's bedside and to meet the patient where they need to be, that's the ideal. At the end of the day, it's all about how do we improve care and how do we get patients what they need when they need it.
And a lot of times people lose sight of that, especially when you talk about labs, where people don't talk about labs very much, but pretty much every patient journey that involves a diagnosis includes lab information.
Yeah, it starts in the lab. People ask me a lot. So I'm a hospital administrator by background. As you alluded to, I've had the opportunity to work in surgery, pharmacy, and laboratory medicine for some major AMCs. And people always ask me how I found my way into the lab. And the real answer behind that is that laboratory medicine touches more patients more often than almost anything else in healthcare. And because of that ability to touch, interact, and provide the majority of patient data, having high-value laboratory medicine is essential to high-value patient care.
So before we dive into the meat of this, let's just talk a little bit about this high-tech thermos you came in here with this morning.
Oh, yeah. It's pretty cool.
Or I guess it's this afternoon now. I've been here since this morning. Health is important.
Yeah.
And all of us, to be good at developing new capabilities that help patients, we need to take care of ourselves. And people talk a lot about hydrating. And I hadn't seen this before, but you actually have a thermos that monitors exactly how much water you consume.
Yeah, we live in a data world, and why not have one more piece of data? So every time you drink out of it, it records how much you've drank, and it sends an alert to your phone when you haven't had enough to drink. And as a busy executive, I know you're in the same boat. You often find yourself going meeting to meeting to meeting and never picking up a water bottle or having a drink.
Right.
So this has been a good way for me to kind of stay present and understand that, you need to take care of yourself occasionally.
It'd be interesting when I'm together with my high school buddies, where you've got a trip planned to the Bahamas.
Oh.
I should get those for everybody and have them drink their beer out of those.
You know what? I think you could have a contest. It does record across the board, and not that I would support that. If not, at least you could rehydrate the next day.
Right. Okay. Anyway, I thought that was pretty cool. And so does it hit you on your Apple Watch?
Yep. My watch hits, I get it on my watch and I get it on my phone.
That is next level. So. Yeah. That actually relates, though, back on topic to the reality that we have all this data that's getting generated all the time, and it's more and more all the time.
Yeah.
And when you get down to the kind of lab, the advanced type of lab medicine you're talking about, where we're getting into subspecialized pathology, the stakes are high because we're talking about life or death.
That's
as you know, my mom died of colon cancer,
Yep.
and would have been here today if she had taken more preventative measures that she wasn't aware of, which super important to get colonoscopies to help with that. She had not had that done.
Yeah.
But then once she was diagnosed back in 2000, there wasn't nearly the level of specificity or tailoring that could be done. And in radiology, it seems like there's a general awareness that radiologists are subspecialized.
Yeah.
But it seems like pathology, where it's another side of that overall world that really gets into what's going to be used to treat you, it's not understood as well. Could you explain this a little bit?
So I think very similar to radiology, right? The idea here is, how do we get the best expert possible connected with the patient to be able to make sure that we're working together in the right way with the right subset of data to be able to create the best intelligent care plan to help a patient through their course of disease. And I think it is incredibly underappreciated just how valuable it is to have someone with really deep expertise in the specific subtype of cancer or sub-disease state that you're dealing with. And what we see mostly today, and this is partially because of ignorance, lack of engagement largely, and frankly speaking, the lack of availability, a lot of folks are getting treated by generalists. Not that they don't do a good job. In most instances, they do a fantastic job, but aren't ever getting that added benefit of having a subspecialist evaluate their specific condition, their specimens, to ensure that when we're creating these care plan designs, they're being created with the best possible data as a foundation.
So, for example, if an individual is diagnosed with pancreatic cancer,
Yes.
there's a pathologist that has trained and is specialized in that type.
With board certification.
Okay.
And what's important to think about with that is, I always equate it to home maintenance and care, right? When you've got a pipe that bursts in your wall, you don't call an electrician. You call a plumber. And there's a rational reason why you do that. That's an individual who has a depth of knowledge in that specific subspecialty, and they're going to be able to more accurately, more quickly, and more effectively take care of the problem. And it's the exact same thing in laboratory medicine. If you can engage a generalist to help lay the table, to help support care of patients at a baseline level, and then when the instance calls for it, have the appropriate access to a board-certified subspecialty pathologist, you're going to get the right diagnosis, you're going to get the right information necessary to develop a really high-value clinical care plan that's going to lead to a better outcome.
So let's be real. No matter what electrician you call, though, they're going to criticize the previous electrician's work.
There's no question. And you know what? That happens in medicine as well.
Sure it does.
And so I have been a firm believer for a long time that medicine is a team sport. And, I mean, you say it tongue-in-cheekly, but the real answer is what we want to do is build a team surrounded and supporting that one patient. And we want to make sure that when there are things that require a subspecialist, we've got that ready access to that subspecialist. Where there are things that maybe overlap multiple areas, you've got the bandwidth and you've got those individuals who can all be pulled together with that singular focus on that patient's outcome.
Absolutely. Now, that's the future that we all want to see. So you were talking earlier when we were just catching up about some of the really promising ways to treat some of these catastrophically, scary types of cancer.
Yeah.
And I was listening with great interest because, I mean, it's exciting what's happening.
Yep.
Would you mind sharing what you were telling me about the pancreatic cancer example?
So what we're starting to see now is new medications being approved with new applicability. And one of the ones that just recently got FDA clearance was Pluvicto, which can be used now pre-chemo. And those sort of changes in indication for medication can have monumental impact on the course of care for patients. And while, certainly I am not an expert in that specific subspecialty, what I can tell you is what's really exciting about that is this is the idea about meeting that nexus of innovation and data being put together to make sure that when we're treating patients, we've got all options on the table, and that when we're making decisions about where and how to treat those patients, we're doing so with comprehensive, clean data that allows everybody to work together collectively to create an optimal outcome. And classically speaking, the ability to access Pluvicto pre-chemo hadn't existed because of outside of clinical trials.
And is this the medication approach you were talking about that used some type of like a targeting that allowed you to go directly to the bad cells?
And with that specifically, there's an entire subsegment of medicine, theranostics, which really has, in my opinion, I think has a real opportunity to be the cutting edge way that we treat cancer for many instances. And that is by tying together laboratory medicine, specifically the use of radiopharmaceuticals and imaging. So we can get a real clean understanding of the conditions that exist inside of a patient at a given moment. We can target treatment, and then we can track the progress of that care. And by being able to do all of those things, we're really starting to get to a place where we're personalizing medicine in a meaningful way that yields better outcomes. And I think one of the things that we all, as folks who have committed themselves to this industry, are interested in, this is not just about creating data. It's about creating information, right? It's about driving medicine forward, and it's about improving patient care. And when we see things like this, I think it starts to get us excited about where the future of precision medicine can go and how we can start to evolve the industry as a whole that towards a directed focus on outcomes.
Okay, interesting. So I just came off a call before you got here where I was being interviewed about the application of AI in healthcare.
Yeah.
And one of the things I said was, right now there's such a lack of the specialists relative to the demand for them.
Absolutely.
That we need to just take the step to try to get to where we can cover a more substantial portion of the demand. There's not an issue with the AI eliminating these caregivers right now.
Right.
I mean, if that ever is going to happen, it's not anytime soon. And I even believe ultimately it just continues to power up and makes those people who ultimately, so to speak, like turn the wrench that much better.
Absolutely.
But I think we'll continue to need smart people. There's a different level of ability to assimilate the information in the situation that a human has. But with that said, it made me think in this conversation, there aren't enough of these subspecialists. It's not like every single place that somebody gets diagnosed with cancer, there's a subspecialized pathologist.
It's true.
So how do we address that?
Yeah, and I think that is one of the pressing issues that we see across the board. I mean, that's clearly a pressing issue in laboratory medicine, but it's a pressing issue in most subsegments of medicine, that we're really just not creating enough providers, and specifically enough specialty providers to keep up with the demand of our populace. One of the ways that WDL has actively looked to address that is through a partnership in what we created, our company Audilon, which is a tech-enabled clinical partnership platform, really with the foundational idea that if we can allow academic and affiliated laboratories to work together and to expand their access to larger communities who maybe don't have access to those subspecialists, we can create pathways for patients to get directed access to that care. Because right now, there's a ton of walls that are up, right? It's not easy to transmit data. It's not easy to be able to establish and connect to those subspecialists. A lot of people don't know even where to find them. And if we can make it easier for people to connect with the right provider, I think we ultimately can help a larger population to get access to that high value care that we know everybody wants and needs.
So who is it in that smaller, let's say it's a rural hospital, that would know to reach out? How does that even become a connection?
And I think that's a problem right now because there isn't a really clean way to do that. So what you find a lot of right now is patient goes into a rural hospital, they end up with some semblance of a diagnosis, and either it's the patient themselves who is forced to reach out and go, I would like a second opinion. I want to go to normally what occurs to be a named institution, right? Something that has a reputation.
Mayo or Sloan.
Yeah, something like that. Or it is a oncologist or otherwise who has built a personal network with other folks in the industry that they know are a trusted partner to leverage. But there's not a great way, or there hasn't classically been a great way to really automate that and to make that more markedly available to all of these small communities. And I think one of the major pressing issues that we have across the board is rural health, right? So how are we making sure that a person who gets that diagnosis in a small town has access to the same subspecialty value as somebody who does it in downtown Chicago, where you have 4 AMCs within 30 blocks of each other?
And just so everybody knows what that is, what's an AMC?
Oh, I'm sorry, an academic medical center.
Right.
And
then in an academic medical center, you're going to have a lot more of the subspecialties and
Yes.
people that are able to bring that more precise approach than maybe a generalist that would be in a smaller.
And again, I don't want it to appear as though I'm knocking generalists. They do a fantastic job. It's really about, though, being able to access someone who has a depth of knowledge and who is seeing these things
It's a team
over
effort.
and over again.
effort.
That's exactly right.
Yeah, you use the example of the electrician and the plumber, and further that metaphor, you've got the specialists in structural engineering who, hey, the overall architect and builder, they know that you need some type of support, but they don't know exactly what kind or how long it needs to be, or because there's a specialist who comes in and says, hey, this is what we need to do
Exactly
there.
right.
And I think that's similar to this example. I think what you're saying about having a team coming together to serve the patient is right on. Now, getting to more of the economics of all of this, so the payers don't always necessarily agree with maybe what is what I would view the best for the patient being what they want to pay for. So
Correct.
if you have a subspecialty or subspecialized pathologist, does the insurance company pay for that? How does that work?
So in some instances, they are willing to pay for a second opinion or an overread by a subspecialist. In other instances, it falls under the standardized DRG payment codes or the standard payments that you would receive for care, which is why, in part, accessing something like care at an AMC has a market advantage, because that is what you're getting for your first read.
Right.
So that is absolutely the case. I do think there is opportunity, in my opinion, for some pay reform associated around ensuring access to subspecialty pathology. But we all know right now that the model that we have in place isn't perfect. But I do think there is an understanding, especially when it comes to what comes next post-treatment, that it is in the interest of payers to ensure that we get those answers right the first time. Because remember, as I like to think of everything is a snowball. So when we talk about care of a patient and we talk about care design, it all starts from the beginning. And if we are starting with incorrect data, we're never going to get to the right endpoint.
Right. It's the garbage in, garbage out.
It's garbage in and garbage out.
So we have War College coming up, which is a laboratory for those who most people don't know unless you're in lab. And it's kind of a strange name. It has nothing to do with the military, but it's a laboratory leader conference that many of us attend. And a topic that has come up that I'm discussing with some folks in a roundtable is digital pathology. And in the 21st century, in 2025, the idea that things aren't all digital yet is surprising to some folks in other industries. But pathology, you're dealing with looking under a microscope and using a slide, and there are certain folks who think making that digital is a great idea. There are other folks that think it's just adds additional steps and cost. What's your view, or do you have one, or where are you guys on that journey?
You know me, I always have a view. But I think it's a really interesting question, because there is no question, with the importance of data that we're talking about coming out of the lab, that digitization has incredible value at a macro level. Now, from an economic perspective today, it's a really difficult ROI justification. Where you see major organizations and major institutions that have gone to a full digital route, in most cases, it's been funded through philanthropy or other means. It's very rarely done purely off of the business case basis. And part of the reason for that is, while we've seen the technology around the actual digitization move incredibly quickly and gotten to a place that is very comfortable, we haven't gotten, we're not fully evolved when it comes to the utilization of comprehensive AI, which can really start to add requisite value. And I am a big believer of, it is important for us to get there, but we need to get there in a controlled and directed way that allows us to move with the pace of technological change. So as an organization, we are not digitized today. As an organization in WDL, we are not digitized today. We do have some elements where we've started to walk down that path, but we haven't had a full comprehensive ROI yet to be able to justify full-scale investment, which is still, by the way, very expensive when you start to think about it. That stated, we recognize that there are areas in which this can really start to add value for us. When we talk about access to subspecialty pathology, we're very lucky. As I said, we have access to full comprehensive subspecialists in our local facility, but the ability to send slides digitally to be read by other subspecialists is incredibly advantageous for patient care. So we are looking at ways to kind of put our toes in the water actively to make sure that we're investing in areas that have more near-term AI application, so we can see a more immediate return on investment.
Okay. There's another wrinkle with pathology that many people might not really think about is there's a specimen there's tissue that's actually being extracted from a human that's been put on this slide.
Yes.
As opposed to radiology where there's an image that's taken, there's no specimen that's taken from the patient. And so with digital pathology, you still have a specimen that has to exist that's maintained somehow, right?
You still have to do the wet work.
So when you hear somebody contest this on the basis of it adds a step, unlike radiology where it eliminated some steps.
Yep.
What's the counter argument to that?
So I think in the short term, it's true. It does add a step because once you've now created that slide, you've got to scan it. And that's true. But when you're talking about adding value, i.e., subspecialty pathology is a great example, where you're going to be able to then take that slide and have it read by someone and not have to ship it. Because that's what we're doing today, right? We're taking this glass and we're putting it in the mail and we're sending it to a subspecialist for an overread or a second read. I think when you talk about eliminating the need to do that, that's where you pick up the value. Now, for a specimen inside of an AMC where you have subspecialists and you're not asking for a second opinion, you're taking that slide that you've created and you're walking 10 feet and you're putting it on a pathologist's desk who's throwing it on their microscope and reading it. Digitizing that slide specifically, is it going to add time? Is it going to add expense? It would. But now you're in a rural hospital and you have no access to subspecialty care, as we talked about, and you're trying to do that. What you'd have to do otherwise is put it in a mailbox, ship it, and wait for that slide to get there and then get that read.
So that's the best argument, is to improve the less well-funded, less resourced care locations. But then those are also the folks that have less money. So how do they go implement digital pathology?
I think it's a fair catch-22.
It is.
And I think this is, like most things in healthcare, this isn't a simple, we should all just do it tomorrow. I think taking a really educated look at this and being very tactical in how and when we implement these solutions is the key to making sure that we're maximizing on value while at the same time continuing to push the industry forward. And I think we have some great innovators in the larger industry who have taken those first big jumps, a lot of them philanthropically funded, but regardless, that's how we get to innovation. And as we start to see, as we alluded to before, some of these AI algorithms add increased value and start to become the basis for standards of care, I think it will force function all of the players to come alongside it, because now this is the net new normal. It's incredibly difficult to be the first in a lot of these spaces. But as we see more and more proof that the utilization of these AI tools not only expands the capacity of our subspecialists, but also can really identify things that are incredibly difficult for anybody to identify, you start to see a value proposition that is much, much more favorable.
Do you think at some point there'll be a digital pathology expert that generates a level of certitude in their read that actually gets reimbursed?
I think, that's a very challenging question, but I think that you will start to see that insurers and and governmental payers will want to focus on outcome and certainty. And the best way to do that is to have these tools that helps not only solidify and prove out diagnoses, but at the same time allows access to these highest level experts. So I do think we may see a differentiated charge code associated with the utilization of subspecialty expertise and or AI.
Okay, interesting. And I remember when Nighthawk first became big in radiology, and I have people who really hate it when I try to relate radiology to pathology, but it's a simple way of thinking about it. And I believe when they were being really aggressive, they would come help instrument these other radiology groups to use them.
They would.
Is that something that you could do in pathology, where you went to these rural hospitals or wherever and you could actually help set them up with digital?
I absolutely think that is something that you can do. And you're seeing it. And the first place that you're seeing it really implemented, I think, substantially is in this idea of remote microscopy, right? You can put a digital microscope in a frozen section suite. So when a patient is in surgery and you need an immediate read, you can have that, slide digitized immediately and be read by a subspecialist in a different location. We're in the process actually of rolling that out right now for our community hospitals. So that's something that you can do at scale, where you could take an academic medical center and say, hey, look, we're going to partner with this rural hospital and we're going to put a remote microscope in their frozen section suite and then have it read by a subspecialist. So I think those are some of those baby steps where you start to say, digital pathology is a huge word, right? But there are pieces of it that are already in play. Just like we talk about AI and utilization in pathology. And everyone's like, well, what are we going to do? We're doing it today. We're just doing it in very specific places. And this is an idea about how do we get to a more mainstream approach where we say we're not going to fight it just on its face value, but rather look at its merits.
It's interesting. I've also seen some cases where the biotech world or pharma world will help subsidize the setup or even fund the setup of digital. But then from a regulatory perspective, using that to do clinical reimbursed work is, I think, prohibitive.
Yeah, it's a no-no.
And so it's just an interesting world where you've got all these different moving parts. But I believe ultimately digital will become mainstream in pathology. Just a question of when. But to your point, the subspecialty needed to get the best possible diagnosis with cancer is probably the driving force that will begin or has already begun to unlock that.
Yeah, I think, again, at the end of the day, it's really important to figure out what outcome are we really after. And if the idea here is it's about providing the best possible care for patients, we as an industry need to do what we can to provide that care. And if we know that laboratory medicine is a nexus from which all of intelligent clinical care plan design evolves, we've got to figure out a way to make sure that we pair the best expertise with each and every patient at the point when they need us. And the best, it's pretty simple that I think at the end of the day, the only way to do that at scale is through some sort of digital offering.
I completely agree. Well, this has been an incredibly enlightening conversation. I know with your 3 big jobs, it's hard to find time to come to the studio. Really appreciate you making it happen. looking forward to catching up here at War College and also at the HC1 event, which will have a lot of fun and have a lot of other smart people that are all out there really working toward making healthcare better for patients and ultimately connecting the dots between how you use this kind of diagnostic testing to understand that people are going to have better outcomes, meaning they get better faster, they feel better, they don't get sick, and that obviously saves healthcare a lot of money. So thanks for all the great work you're doing in this space.
No, and I really appreciate you, having this entire podcast, because I think you're shedding light on some really difficult topics and making them very digestible for people, which I think helps all of us when we can get to a more commonplace understanding.
Awesome. Well, thanks for being part of the Boombastic Health community. And thanks, everybody, for joining us. We'll be back here shortly with The Verdict with Emily to talk a bit more about the legal and regulatory implications of moving to these kinds of subspecialty services and digital pathology. Well, we just completed this very enlightening conversation with Steve Serota, who runs the largest lab in Wisconsin with WDL and is part of the Freighter Theta Care system, and really was bringing up the importance of subspecialized pathology as it relates to diagnosing cancer, which certainly if any of my family or friends or I had that issue, I would want somebody subspecialized to help with the diagnosis. So moving into The Verdict with Emily, it just so happens that this is a topic that Emily has a lot of experience with because digital pathology is an enabler for making subspecialized pathology available to all different health systems, not just the large medical centers that are more academic. Emily, welcome to the show here, and would love to hear your perspective on what you're seeing as this space keeps evolving quickly.
Yeah, I mean, I think Steve's right to be able to leverage subspecialty expertise. That's really difficult to do in a traditional glass slide setting. And digital pathology gives you the ability to send slides across state lines to those pathologists who are the most qualified to read a specimen. Obviously, there's a physician licensure component that comes into play. The docs have to be licensed in the state where the specimen originates, but that's relatively easy in light of the fact that you're creating this ability to more accurately diagnose conditions and get patients on the right treatment plan, as opposed to, a pathologist is good, right? But if it's a dermatopathology specimen, you want the best dermatopathologist looking at your specimen. Same thing with, NASH pathology. All of those different specialties are really, really critical, and it is important to be able to leverage that particular expertise. And so we have a ton of pathology clients who are trying to stand up their own digital platform, and it's hard and it's expensive and it adds a step, and people get frustrated with that, especially the older folks. But the younger pathologists coming out of med school expect there to be some sort of digital component. That's what they want. I think that's how they're partially trained in residency, and to be able to use that, it gives them both like the personal freedom that they want, but it gives them an ability to build this really great practice and leverage their expertise on a national standard.
Yeah, another interesting point that Steve made was that as artificial intelligence models get employed within pathology, and you'll need to be digital to take advantage of those models. And that'll be another enhancement that really will lead to, I think, ultimately more consistent, better diagnoses at scale, where you can bring more of these expert level interpretations to people that are in need. And so when you think about more of the academic medical centers, though, Emily, that have pathologists that are subspecialized, they're in the same building or same department, or they're working together and they're available. What's your perspective on digital in that context?
I would say even with like the very large academic medical centers that we work with, there is a push to create a central repository and a digital platform because it's more efficient for them. It's also can reduce staff and costs. I guess the corollary to that I've heard is that enables pathologists to practice longer because it's a little bit easier on the eyes, a little bit less burdensome. And so folks are practicing longer, whereas when they were reading glass slides, they were, retiring sooner. But the large academic medical centers we work with are very much interested in adopting a digital platform. The problem is they move super slow. To your point about them already having in-house experts, that's true. They do, but I think when you adopt a digital platform, you can leverage slide processing facilities across the country. You can create a bigger footprint and leverage specimens from a greater catchment than what your maybe normal geographic footprint might be.
Yeah, it sounded like in Steve's case, they're actually playing offense in using digital within their environment to support other practices that are around the country, ultimately that could benefit from their subspecialized pathologists. So it's like it's a form of outreach where
Yep.
they're able to use those services. So, well, certainly,
To your
yeah.
point, sorry about AI. There is a group down in Texas. In fact, there's a presentation about this at the War College in a couple weeks about using AI for secondary consultations, which obviously was being done in a digital platform. So it'll be an interesting presentation, and they've had some pretty good traction on that. So probably more to report on that subject in a couple weeks.
I would love to join for that one. I was not aware of that session. So good job being so proactive with looking at the agenda way before the day before the conference. So, all right, excellent. Well, thanks so much, Emily. Appreciate your perspective as always. And thank you all of the friends of Boombastic Health out there for joining us. Have a great day. We'll see you next week.